You can see here, resident competence in PBL and I is first customer knowledge. Is the resident able to identify the needs within a resident's patient population, whether that be in an internal medicine clinic, a surgical clinic, a psychiatry clinic or ward? Do they understand what that patient population needs in order to receive high quality care? Second, they need to know how to do measurement. Can they use balanced measures to show changes have actually improved patient care, particularly the patients they care for? A good example here would be, can they use the measures that denote high quality care in diabetes, such as making sure that patients' blood pressure is below 130/80, or that their cholesterol is being treated to ensure that their LDL level is below 100. The third is making a change. Can they demonstrate how to use several cycles of change, which I will review with you in a moment, to improve care delivery? This again almost always requires a change to the system in which they're working, which gives them an opportunity to make that change so that when they go out and enter their own practice, they're able to do that in that new setting. And then finally, developing local knowledge. Can they apply continuous quality improvement to discrete populations or different subpopulations needing attention? Again, diabetes is a good example. We know this is a highly prevalent chronic disease that has substantial health implications for patients whose diabetes is not well controlled. Can they apply continuous quality improvement to a group of diabetics that they're responsible for in their clinic? Would be an example developing local knowledge. With regard to systems-based practice, competence, again, good enough to graduate, starts with understanding and being able to describe the reactions of a system, particularly perturbed by a change initiated by the resident. So again, looking at healthcare as a system activity, and a good example here that we don't spend enough time actually helping our residents or other trainees understand is that when they're asked to get an urgent order, such as told by the attending that they need to go down and get this CAT scan for this patient today, do they fully understand that if their patient gets the CAT scan, it usually means another patient does not, or that another patient will have to wait to get the CAT scan they originally scheduled for? So anytime that they make some change to the system, they are perturbing that system that often leads to a cascade of effects. And helping them understand these interventions or interactions that they create affect other patients or affects the system is very important. Second, collaboration. They need to learn to contribute to interdisciplinary efforts. That means working outside their comfort zone with just physicians and learning to work effectively with nurses, pharmacists, discharge planners, social workers, administration, and on and on. Collaboration is critical, and it's a critical element of good teamwork. And then finally, the social context and accountability piece. Can they demonstrate the business case for quality improvement and identify community resources? Again, most of our patients do not live in the hospital. They spend most of their time in the outpatient setting, and they spend most of their time at home. So how do we identify the community resources to enable them to care for themselves effectively when they're not encountering the healthcare system is just as important as when they're in a healthcare setting. And so understanding that social context accountability is an important system skill. Now the ACGME has actually listed a number of expectations for system-based practice. And I think these are very helpful because it actually describes in roles or actual behaviors what it is residents and fellows need to be able to do. Expectation number one is, can they work effectively in various healthcare delivery settings and systems relevant to their clinical specialty? So if I'm an invasive cardiologist, I need to be able to interact and work effectively with the emergency department to make sure patients are identified quickly and transferred quickly to the cath lab. I need to work with a team in the cath lab to make sure that the catheter is thread safely and quickly to open up that blocked artery. I need to work closely with the critical care unit that I showed you earlier on the microsystems diagram, and so on. And so it's important for these people to understand all these different settings and how they need to work effectively as a team member in that setting. Expectation number two, they have to be able to coordinate patient care within the healthcare system relevant to the clinical specialty as well. Again, If I'm a cardiologist and I'm discharging a patient to cardiac rehab, I need to make sure that that appointment is set up properly, that the patient knows how to get to that appointment, that the physician and team on the end receiving the patient in the rehab facility understand what that patient's needs are. So care coordination is a critical systems activity and a critical system skill. Expectation number 3, incorporate considerations of cost awareness and risk-benefit analysis in patient and/or population-based care as appropriate. I know that all of you are aware of just how expensive the U.S. healthcare system actually is. In fact, estimates now put U.S. healthcare expenditures at 18% of our GDP, and we all know that this is unsustainable. It's also clear from multiple studies that we overutilize tests, often use drugs that are more expensive than cheaper alternatives, and it's very important that our trainees understand this and be very aware of resource use and apply the best evidence as well as cost awareness when choosing what's the most appropriate therapy for patients. Expectation number 4, it's important residents and fellows advocate for quality patient care and optimal patient systems. Again, this means they have to be an active agent in improving systems. They can't be just passive bystanders. If they recognize a problem, particularly in a work process, for example, it is their responsibility to identify what that problem might be and at least provide some input or awareness on how that change might occur to improve whatever system problem they've identified. Expectation number 5, as we said earlier, they need to work in interprofessional teams to enhance patient safety and improve patient care quality. Again, this requires an active participation on the part of trainees in improving the very microsystem in which they're working. Expectation number 6, participate in identifying system errors and implementing potential system solutions. You can see that these are all tightly connected, and it's important, again, that the trainees be active participants in making the microsystems in which they work better. So we can take these 6 expectations and actually look at them as 6 specific resident roles. The first is they need to be a system consultant, they need to be a care coordinator, they need to be a resource manager, a patient advocate, a team collaborator, and a system evaluator. These roles are not only important for them to be effective during their training program, but these are very much the same roles they will need to take on as physician leaders in the microsystem that they will ultimately work in as independent practitioners.